This is No Operating Manual, a podcast about building healthcare companies when there's no one clear path and no operations manual. Dr. Michael Pitt is a pediatric hospitalist, a professor at the University of Minnesota Medical School, and co-founder and CEO of Q Rounds. Q Rounds is the first of its kind virtual rounding queue that sends real-time notifications to patients, families, and nurses so everyone knows exactly when the care team is arriving. The idea came to him while waiting for a haircut at Great Clips. The inspiration, a text telling him he was third in line. Since then, Q Rounds has been used by more than 60,000 families, tripled nurse attendance in rounds, and cut harmful medical errors by nearly 40%. Mike, welcome to the show.
Thanks for having me, Erin.
So take us back to that Great Clips moment. You're sitting there waiting for a haircut and something clicks. Walk us through what you were thinking and how quickly that idea turned into something you decided to pursue.
Yeah, I've gotten to experience healthcare from every side of the bed in the hospital room. So I am a pediatric hospitalist, which again means I take care of kids sick enough to be in the hospital. I don't have a clinic. My clinic is the hospital. So I know that well. I know as an administrator and a hospitalist, and often had felt the pain points of showing up to the room and the family wasn't there, the nurse wasn't there, the patient was asleep, or a child. I couldn't give an update without the family, and had felt that expectation of, wouldn't it be nice if we could all be there at the same time? I felt that again when I had loved ones hospitalized, my dad, my mother-in-law, my father-in-law, for months at a time, where I was begging for doctors to call me when the family entered the room, or I was sitting in the bed at the bedside at 5 a.m. to not miss that important discussion. So all of that is in the background of my life, while I'm sitting in scenarios consistently being given the dignity of knowing when something will occur. So I'm at a Great Clips and I'm getting texted that I'm 3 away from my haircut, and it makes me realize I have time to run next door and get a Starbucks, thinking if Domino's Pizza and Olive Garden and Great Clips can give me the dignity of knowing when to expect something, why haven't we figured that out in healthcare? So that led to kind of the aha moment, which nagged at me to get a grant and find someone to help me build that app for healthcare.
Again, you had experienced this, but was it like, okay, I can make this happen? Was it a light bulb and then it turned to, okay, let's go develop this? Or had it been festering for a while?
Yeah, festering is probably the right word metaphorically, and the long journey of it. So yeah, I think it started with, gosh, wouldn't it be nice? Why can't we do this? And I pretty quickly, there was an opportunity for a really cool grant model at the university called a progressive grant, where 20 people can apply in the department to get a $5,000 grant with just a paragraph. And then 3 months later, those 20 winners get to apply with a page summary of where they are for $10,000. And it moves all the way up to 100,000. But it's a nice way to get a lot of people to get the gateway drug of research, starting to get them interested. So I said, well, for $5,000, could you help me build the Great Clips app for healthcare? And we would say, I'm going to focus groups and families and figure out what this would look like. And so I met a colleague who's now the co-founder, John Sartori, a professor of computer engineering at the university. We met for lunch and I said, hey, could you help me build this Great Clips app? So that happened pretty quickly. And I think part of the reason we were successful is we didn't let what we didn't know keep us from taking that first step. I often am mentoring people when they want to write a paper, and it's like they feel they have to know the journal it's going to, know how many words it is, and it's like they just need to open a Word document and start. So this was the equivalent for that for us. It was, well, let's not think of all the reasons this couldn't work. Let's say, could we build this? And I've learned that developers, the answer is pretty much always yes. You can build something. It's kind of a reverse, or like a field of dreams kind of mentality. It's like you can build it and we can iterate on it is always the answer. Should you? Is there a market for it? That's something that we kind of had to learn along the way. And I certainly had to learn that just because we could build something that did the right thing and invited families to participate in hospital rounds didn't mean that would be a reason hospitals would pay for it. And so that journey is a whole separate, process.
$5,000 doesn't get you very far. I mean, that scrappy version of Q Rounds. How did you take that initial version? Did you get to that $10,000, that $100,000, or tell us about how you took that initial version and tested and learned from that?
So yeah, I mean, it started with, again, didn't even know this vocabulary yet, but we were creating the wireframe demo, of what would this look like, building in PowerPoint kind of a box version of what I would like to build, and started to just share that with nurses and doctors and kind of get some feedback to build
Mhm.
out what we would build internally. And again, John, the answer was yes. So he built out that demo. We made the first $10,000 follow-up grant, but we were spending that on very little, like servers and some design work to kind of get that going. To answer your question, we made it all the way up to I think we got $35,000 total from
That's
that
great.
grant, but it allowed us to do focus groups and build a demo version that worked and was EHR agnostic, did not talk to the electronic health record, but gave us that workflow. And we were able to test that out in COVID. The very first live patient that got the Q-Rounds experience in the neonatal intensive care unit, the family was not allowed in the room because of
Mhm.
restrictions on visitors at that point.
Mhm.
There was not enough PPE for the staff, so the medical students weren't allowed in the hospital. And our very first Q-Rounds patient was a patient in Minneapolis. The family was in Duluth. The med student was in St. Paul, and they were all texted at that time a Zoom link to join for rounds. And so we built that EHR agnostic version with that initial startup funding, so to speak.
That's amazing. When you think about that issue, so the coordination issue, why do you think no one had solved that before? Was it a culture gap? Was it a technology gap or
I think
process
there's a
gap? I don't know.
handful of reasons, and it's a question we remind ourselves of it all the time. So this is a very easy solution to say out loud. You don't even need an elevator ride. It's like an escalator pitch
Mhm.
to tell
Yeah.
the story. And it's, if you've ever had a loved one in the hospital and you didn't know if you could get a cup of coffee or go to the bathroom, wouldn't it have been nice to get real-time updates, just like an Uber driver, of you're fourth to be seen, third to be seen, and if you couldn't be there in person, you could RSVP to join remote. That's
Mhm.
the solution we were building, really by patients for patients, solving for that problem. We then realized that, again, even though that's a solution everybody has experienced, if we don't make the doctors' lives better, it won't get used. So, really, what is the case for clinicians to have that? Now, it's obvious to me, but it's to have that team there waiting for you. We know that there's a nearly 40% reduction in medical errors when the nurse joins at rounds. They're not getting included because they don't know. The number one question asked every day is, when will the doctor be here? And there's no way for them to answer that question. So if we could solve it so the nurse knew, the doctor knew everybody was waiting, and the family was able to be present, we would be a unique technology that was built where every user thought it was invented for them.
Mhm.
That's a sweet spot. And I think we've found that. We have nurses say, where's this been all my life? I get to take my lunch breaks again. Families saying I didn't have to quit my job to be present for rounds because I was able to be notified through Q rounds. And doctors saying, I'm getting to see 6 or 7 times as many families in less time, saving me all that time and update, and also connecting me with families in a way I wasn't used to. So I diverted on your question. I'll get back to it. But first, it was the fact that we were solving something for everybody was a way I don't think people had thought of this problem before. And so
Mhm.
you might solve something that was great for families, but the doctors wouldn't use it. And
Yeah.
I think being the physician founder gave me a unique lens to know that this had to work for all of them. So one reason it didn't happen, I think, was, and we've had people come up to us at conferences and say, how did a startup come up with this? And they realized that you needed a nurse and a doctor's lens pretty early in it. Two, rounding is a remarkably linear problem on paper. I need to go from this room to this room to this room. And so you think, well, why, if FedEx can put items on a truck and you can follow the truck on a map, why haven't we done that in healthcare?
Mhm.
Well, it's because in healthcare, those packages burst into flames. Somebody gets really sick. It falls off the truck. 5 new packages get added in the middle of the route. So it's a remarkably complex, some of your package recipients don't speak English and you need to have an interpreter there. The nurse may be in more than one spot. So a simple problem on paper becomes remarkably complex as you actually solve for the nuances of rounding. That's why I think it took us so long to get live and have something that's intuitive and works every day for every patient.
So then how do you solve for those packages that fall off the truck and that get added onto the truck? So all of those changes along that happen day to day.
Yeah. So the key is that this is not a schedule. It's not, the way Q rounds work, it's an EHR integrated software that only the doctor or rounding team member has to download. Nurses and families don't download anything. It pulls their electronic health record patients that they need to see that day in, allows them to flag the sickest patients or those that are ready for discharge to be bumped to the top
Mhm.
of a rounding queue. And then they can sort by their own preferences. When they hit share, 3 things happen. Nurses get notified, they get pinged. Dr. Pitt has shared his rounding queue. You have 3 patients together. Your first is at 9:15. The second, it pushes it back into the electronic health record so everyone with Sightline can see that real-time rounding queue and make decisions like care coordinators and discharge pharmacists. They know when we're going to be there. And the third, the family gets a text message. If you've ever stayed at a hotel or gotten a text from your airline that your flight was delayed, it's analogous to that. They get a text, they're able to click on a link, see their position in the rounding queue, and RSVP if they can't be there in person to be pulled in automatically when the doctor enters the room. So one of the ways we solve for that nuance is each of those users thinking about what is it they need to participate in rounds to build a dynamic cloud-based queue that is modified in real time. So if you're taking longer in one room, it updates everything downstream, allows you to pause rounds, to split the queue, really to think of all the ways a doctor might be burdened in the middle of rounds, but still want these messages to go downstream. And then to condition families that this is not an appointment you have at 7 a.m. It's a real-time update of when we expect to be there, and that's going to change dynamic.
The data is pretty amazing. 197% increase in family presence, a 215% increase in nurse attendance, and a 38% reduction in harmful errors when nurses are at rounds. Were you surprised? I mean, it sounds like the Q rounds was really an efficiency app, but this is a care efficiency that's reducing cost of care.
Yeah, and what we knew all along, there's a best practice in healthcare, especially in pediatrics, to add this middle part, but it's called multidisciplinary, family-centered rounding. So you have the family present for the discussion. They're not hearing it through a telephone game, or where often the person relaying that message is a sick patient that says, yeah, the doctors were in here and I was half asleep and had just been put on pain meds, but here's the plan for the day. So family center means you're getting the family of the patient present, multidisciplinary nurses, social workers being. That is a best practice that is done less than 5% of the time because coordinating all of those connections. I joke, if they had an episode of George Clooney on ER tracking people down and trying to get prior authorization and get the right people, a whole episode of them on the phone, a lot less people would have gone into medicine. Yeah, that is so much of the work, is the grunt work. I don't get to walk in the room of a 3-day-old when the family's not there and say, okay, tell your mom and dad what we talked about. I now have to play this telephone game and track people down. Q Rounds is automating that. So we knew that this best practice exists for a reason. It reduces medical errors. It increases provider and nurse satisfaction and family satisfaction. It decreases bounce backs to the hospital when you have the family on board. So we had this unique position of saying, we can be the thing that makes the best practice that's proven all these outcomes exist. So we make that best practice an achievable standard of care. So to answer your question directly, it isn't surprising to us that those benefits are now being manifest of decreased errors, decreased malpractice claims, increased admission, discharge speed, and nurse provider and physician satisfaction, because we knew that would happen if you could only get everybody in the same room, and everybody had given up on actually how to do that.
Switching gears, the university spun Q Rounds off as an incorporated company. I know that you roll your eyes at the word entrepreneur, but what is it actually been like to take on the entrepreneurial aspects of fundraising, pitching, sales, all that kind of stuff?
Yeah, and the only asterisk I would say is I used to roll my eyes at it. So I think, I would see the word entrepreneur and I thought of the title card on Bachelorette and Bachelor episodes. Everybody's an entrepreneur. You can, whatever you're saying, I'm an entrepreneur. So I just never identified with that word. I recognize that some of that is I had this absolute privilege of coming from a job. I had a university job. I had an identity as a physician and a professor, and I got to kind of flex that into this thinking. So I also understand if you're going all in, that label is probably really important to you. It was less important to me. But what I've learned is, wow, if you do it, if you actually get to where your thing is being used and people are having jobs because of it, and that it means you did every job in the world for at least 5 minutes. You were a banker, a bookkeeper, a marketer, a designer, so I have a new respect for what that means when you've kind of hit certain milestones of what it means to accomplish that I never had before. I think what helped me as an academic, I am used to rejection. When you're submitting a peer review, I've published well over 100 papers. it is very rare for your paper to be sent and accepted. The norm is rejection and move to the next piece. And John Sartori had that too. And I think the combination of the rejection resilience, the fact that we both are not able to pick teams in our world, you show up to work and you're on the team, means you can work with anybody. I think those were two unique things for us as founders that gave us some unfair grit to start and kind of accidental founder skills that we weren't thinking we were learning, but helped us move on. Then knowing what you don't know and just realizing the jargon of entrepreneurship. What is a safe note? What is fundraising? All of this stuff. What is an angel round? Just being really comfortable asking those questions and being vulnerable, I think was a huge part, which again, I think our identities as an MD and a PhD allowed us to be vulnerable and acknowledge we didn't know. And those that are maybe all in that entrepreneurial space might have a bit more imposter syndrome and feel less comfortable asking those questions, feel that they should know the answers, whereas it was very easy for me to say I didn't. So I think that was part of the journey. The university was a great partner in coaching up that language and allowing us to kind of spin this off to be successful with them on the cap table as kind of that first champion.
I love the analogy of, the team's already picked, you're just part of that team. So you basically are there to manage within that space. I guess my question is, academics being part of the university system, it's a little bit different feel in terms of like hierarchy, right? Tenure versus non-tenured, and I guess that it would be an interesting position as you're building something that has to move fast and has to adopt a little bit faster than a typical academic or even healthcare.
Those are great points. I think the speed is something it took me a while to learn that and include a couple things. One is I'm a scientist first. So I was not comfortable being the CEO that sold vaporware that was like, I got an idea. We're going to get people to invest in this idea, whether or not we know it works. That cost us some time because I was a researcher to prove that this actually works. Those numbers you gave are actually from the first peer-reviewed study of the Go Live. We've since done a follow-up 2 years later, and those numbers continue to increase. We had another doubling of family involvement 2 years out without adding any timed rounds. So we've continued to study, but I think that has slowed us down a little bit. In fact, one of my mentors that started as an academic and has a startup said the mistake we made is we kept studying things. Just once you have it, get your story out there. And that was helpful advice. But the academic hat has allowed us to pursue grant funding. So we have an over $2 million non-dilutive small business grant through the National Institute of Nursing Research that funds development of some of our core features. That's quite a unique business posture to be in. But I think that the slowness is a absolute trade-off on that academic. And I've had to learn to be speedier. I've had to learn to be more comfortable with marketing speak sometimes than I would be with peer-reviewed p-value speak. That's taken me a little bit of an ethical adjustment, honestly, of what does it look like to be able to say something that is true, but might not get past peer review, which is a challenge. And then I would say, even what I hinted at, the ability to work with anybody is not a great skill as a CEO building a team sometimes. I think it's caused me to be slower to say when somebody is not working on the team, now that we have a dozen or so Q-Rounds employees. And I've had to learn that pivot too, of what I have to make a fiduciary responsibility to Q-Rounds when I'm used to being able to work indefinitely with somebody, for example. So that pivot has been a learning point for me too.
That's really good insight. What's been the biggest obstacle, though, overall in getting into these hospital systems and getting them to say yes to the software?
Yeah, there's two answers. One is the margins in healthcare are really tight right now. So just the dollar spend on anything. And I think that's where the ability for us to show ROI, but also show that could come in through many different offices as something that gets championed from we have a system we're going live in North Carolina where we're going through their patient experience office. Similarly, in a system in Texas, where we're going in kind of through that patient experience commitment versus others that are saying, we need to solve a problem in our NICU. If you're a software that has one buyer, you make an algorithm for EKG interpretation, you've got one buyer. But the fact that we're moving the needle for so many users is actually an obstacle overcomer for us. That said, sales cycle is long. There's no
Mhm.
such thing as telling the story once and somebody saying, oh my gosh, where do we sign? You need to tell this to them and they need to tell this to them. So, that kind of 20 meeting to initial sales cycle, I would say, is probably the biggest obstacle. That's why the grant funding gives us a bit of cushion while we're building out some of these features and have done a venture backed round. It extends our runway to feel that we don't have to get 50 customers right away. We can really do this in a methodological path.
It's interesting because typical company startup would develop their ideal customer profile and they'd be every single time they'd go to that. But what you're saying is there are many different ideal customers within these health systems that you can target as a way to leverage your way into an organization and then sell through to the entire organization.
Yes, we attend a neonatal nurse conference. And again, NICUs are a part of our go-to-market strategy because by definition, every baby in a neonatal
Mhm.
intensive care unit has a family member that needs to be updated.
Yeah.
Often they're there for months at a time and family is back at work. We've heard over and over again families say, I did not have to quit my job. I did not have to sell my house because of Q rounds. And that they weren't having to make the choice of being present for their
Yeah.
baby
Yeah.
versus their job. And so that's our go to market. So we've done neonatal nurse practitioner and nurse leadership conferences and had huge champion success there. We'll be at the American Hospital Association Leadership Conference in Denver in July. That's hospital executives. We've been at HIMSS, which is kind of more
Mhm.
the tech
Yeah.
thinking digital health leads. So it is a unique, now it's probably more expensive on our end than just knowing we have a single target.
Yeah.
I think it makes it kind of fun. We have one of our newest hires in Q Rounds is a former nurse, still practices, but is a primarily in the sales digital health space now, and love that she will bring that nursing experience as we go to these meetings too.
I think having those multiple contacts is huge because you build that ambassadorship inside, you build that momentum inside before you even show up in the room, right?
Yeah,
For
absolutely. And
some of the
the amount
conversations.
of times we've entered a meeting and said, "Oh my gosh, I heard about Q rounds from
Yeah.
so and so," that the only naysayer I would say in this story, if we ever get anybody occasionally in adult medicine where they're not used to having to update families every day, like when
Mhm.
you're taking care, there's some initial fear that, oh no, is this going to add extra time to my day? And we're showing it's decreasing the time spent on the phone in follow-ups, for example, because you have everybody present for that most important moment. You're not having to follow them up later in the day. But that's the only voice that they sometimes need to bring me on a call to kind of counter or spar with a bit.
Q round started in peds, you work in peds. It makes sense that you would stay there, especially, as you're starting out. But obviously adult medicine, it's clearly an opportunity. What is that roadmap? Like where do you go from here?
Yeah, our systems both in North Carolina and Texas that are going live are primarily adults. So we'll have a lot of really neat opportunities to learn there. Again, nuances, just an easy example in pediatrics by default, the parent is going to be someone that legally can get an update. You have to think about this a little bit differently. The adult patient needs to consent into who they want to receive those updates. And you
Mhm.
can't just pull from a EHR field, for example. So it's been fun to kind of figure out some of those problems. But yeah, we will have again, if any of your listeners have ever been the child of someone in the hospital, they're everybody's saying, I wish I had this. And so
Yeah.
we just need to figure out that workflow in that adult space. The ICU setting of an adult hospital is an ideal first place for those reasons I mentioned before. The patient's often not able to communicate for themselves to be the middle person of those family conversations. And they're often there for a longer period of time, which I think really makes this attractive.
I think in geriatric clinics and geriatric medicine, I think this would be huge. Does it change your product at all? You said that, obviously from an EHR and distribution of communications, but does your product change at that point? Or is it
There are some very,
additive?
very simple toggles that would exist in this adult versus peds experience. For example, a rounding provider might not want every update to involve the family, whereas
Mm.
so we're playing with some nice features in that space that create some toggleability based on adult versus pediatrics. Really, what we see ourselves as the technology that one allows your existing technologies to do what they said they would do. So there's a whole movement in healthcare for the smart room, the ability to pull people on video into the patient room. Families would love that, except they can't be just pulled in on demand because they can't be sitting by a device for 6 hours waiting for the doctor to come in. The time transparency that we provide allows us to partner with companies like Caregility, for example, is a main player in that smart room telehealth solution. We are doing a partnership with them where families will be able to RSVP and be queued up on the television when the doctors wait in the room. So the ability to allow your smart room technology, a lot of your throughput, the bottlenecks, we own the trademark time transparency. And that's what we're doing. We've come to expect time transparency in every arena of our lives. Where's my package? Where's my haircut? When's the table ready at the Olive Garden? Yet we abandon it when it matters the most. We're looking to say, well, what does time transparency look like in the emergency department? When somebody's waiting for a room and we can address the bottlenecking of getting the accepting physician and nurse on the call together so we can get that patient up to a floor. So I think there's a lot of opportunities for us to not just solve this nice to have, wouldn't it be nice to have the family there? But the number one question in the hospital is, when will the doctor be there? The number two question is, do you guys even talk to each other? And so the ability for us to get all those team members in a coordinated connection is a big part of what we're launching with our next suite of products.
So for a clinician who's sitting on an idea right now, but doesn't exactly know where to start, what would you suggest is the first step?
So one of the things I didn't have with this was generative AI to do some of the work for me, to say kind of what's out there in this landscape. Here's my idea, what exists. And I think one is do some of that work. Now, one should not be scared of, oh, somebody's doing this already, the end. There are absolutely reasons. And nobody was doing anything in this space, but we know there will be competition, and it's our job to be ahead of that and have already created things that are intuitive and adding to solutions that we can add to. But I would say step one is put your idea at least in sparring with ChatGPT or Claude, where you're able to kind of understand a little bit. And then who's the person you can meet with for coffee? That's your first next step. Could this be built? Do you have somebody in your network? Are you looking to vibe code some solutions? Though I would say you're not going to get into a hospital with a vibe coded solution. You need to have a professional team, but the ability to build out some workable prototyping to be able to think. And then how much of this can be bootstrapped before you have to raise money? You have to have, for a hospital to turn anything on, you have to have security compliance and things that just, and insurance that cost money. Are you going to do that? Are you going to put a story together and get out to some of the angel networks in your area to be able to raise?
So wrapping this up, what advice would you give to new founders, kind of in that same step as the clinician, but overall founders, as you're building your business, as you're building Q rounds?
Be married to the problem, not your solution. I think a lot of times you can tell a company that is committed to solving a problem versus has an idea for a technology that would solve the problem they think it would work, the way they think it would work. I think that's a setup for failure and ability for anybody to just code what your idea is as well. But if you're laser focused on a problem that you want to solve and the technology is part of that solution, but it's going to be evolving throughout, as is the rest of your suite, and you're so committed to the problem that you would throw away the original idea to move towards the problem, I think that's what separates the companies that are successful, which I wouldn't put ourselves in yet. I mean, we've hit landmarks, we've had sales, and I try to celebrate the individual milestones of, my gosh, we had a patient use this. We've had over 60,000 families join rounds remotely. We've not had a day we've been live in the NICU that they've chosen not to use this. But it is those little moments too of, we have a dozen people who call Q rounds their job, who pay their families, who feed their families based on an idea I was doodling in the steam on the shower. Like, that is a fascinating pride moment for me to try to own. And I would encourage people, I'm wearing, for those that are listening to this, I'm wearing a Q rounds vest. I bought a vest, I made a Q rounds thing, and I ironed it on. And it was this, the tech bro, everybody has a vest in technology. But when I put it on, it was the first thing I owned that said Q rounds on it. And I said to my wife, this is fully vested. This is what it means to be fully vested in the company. I have something that no matter what happens, I have a vest. And I get to say, remember, I did that thing called Q rounds. And so I try to own fully vested moments. When we had a retreat and we were all together laughing and bonding over this, if nothing ever happened, we all got together in Utah and got to know each other. And that's a fully vested moment. I try to own those along the way, that if an exit happens and whatever startup success looks like is gravy on what's been fully vested in the present, the story my kids get to see of the resilience along the way. My daughter and I were swimming. She was maybe 10 at the time, and she's 14 now. And she said, "What's the best decision you've ever made?" And I said, "Moving us to Minnesota,
Oh.
like the life that we have here." And she said, "What's the worst decision?" And my instant answer at that moment 4 years ago was starting Q rounds, coming up with the answer, coming up with this problem and committing to it. And I just came out in the pool. Like I wish I could go back in time and uninvent this. 10. And I'm realizing she needs a copay for the therapy moment that this was. She's like, "Well, why?" I said, "It's just really hard." Like I did, I watched Price is Right before coming up with this and had downtime and took naps in the day. And, I didn't, it wasn't this wasn't why I did it to be a CEO of a company. And so that now I can answer that same question if she was asking me that today. She said, "What's the best decision you made?" I would say founding Q rounds. And so I think knowing you're going to want to give up is part of it. Also knowing it's okay to give up. Having started something is never reason enough to finish it. It's a unique American culture mindset that is not the rest of the world. And so I think constantly a finger on the pulse of that is probably a longer answer than you were looking for.
No, that's a great answer. That's an honest answer that at any given time you could want to quit or you want to just keep going. It's the best and the worst decision is probably a lot of founders can feel that.
I mentioned family. My dad, my mother-in-law, my father-in-law died in the 3 years we were building this. All long hospital journeys and cancer and falls and all the stuff that you deal with aging parents. But there was a season of grief afterwards. I immediately went from my mother-in-law's funeral to present Q rounds at a meeting in Vegas, and I looked down and I had packed two left brown shoes. As my only shoes and slippers, and I wore the slippers and a suit into this pitch in Vegas, you know, blinded by grief. And I went back to the rooms like, oof, this is not what I want to do anymore. Like I was hit by the grief and was ready to pull in a CEO that could kind of run with this. And I think the one realized that you need to check your pulse and was in therapy and navigating some of that, decision making constantly, but also that it's okay to have thought that and then realize, no, I am the best person for this, and not be ashamed of your own internal pivots in those moments. And the grace my team has given me in navigating those decisions out loud, I think has been a real vote of confidence and important for me too.
That is a beautiful sentiment. Mike, I really thank you for joining me today and sharing your advice and your wisdom and the story of Q Rounds. I look forward to seeing what you all do in the future.
Sounds great. Thanks for being out there and for having this space for founders.
Thanks for listening to No Operating Manual. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and a review, and don't forget to subscribe on YouTube. No Operating Manual is hosted and produced by Erin O'Brien of Chemistry, a healthcare marketing and communication advisory. Visit our website at choosechemistry.com.